Now, so let's recap real quick because you guys are done with this cardio business anyway, for the most part. We said with the cardiac patient that's having CHF that there was a right and a left side. We said that the right side was venous and as such was going to give you signs and symptoms of venous congestion. Every vein in your body was going to be congested. It also, we said, when it came to the right-sided heart failure, had everything to do with the fact that venous return was an issue. It affected preload or volume. We said with the right-sided heart failure that there was some lung disease that actually preceded it. The patient with right-sided heart failure had another name for it, and that was cor pulmonale, because at the core of the problem was pulmonary disease. Left-sided heart failure was more arterial. Arterial disease caused it, not lung disease. Left-sided heart failure had the potential to become both left and right, because if you back up the blood, it's going to go in the lungs. If you overwork the lungs, it's going to go on the right side. With the left-sided heart failure, we said to consistently remember afterload. With afterload, you were basically told to remember resistance. And so things like smoking and atherosclerosis and obesity and all this were going to affect the afterload or the resistance that the blood has when trying to get through the blood vessel. When we had a left-sided heart failure, we had lung symptoms very often. That's what we experienced, lung symptoms. We also experienced the fact that the blood never got to the toes or the nose, and so your patient was cold. They were at risk for fainting because there's no oxygen to tissue. They were cyanotic or pallor. They had hairless extremities. They had, you could say, poor cap refill. I mean, you have to consistently stay with arterial circulation issues. They had painful ulcers. If they were going to get any ulcers, it would be painful. The care of the patient with CHF, we said, was diagnostic-wise going to be looking at the BNP and the ejection fraction. We said to remember the 50-50 plan and that the BNP was greater than 50 and the ejection fraction was less than 50. The ejection fraction was usually determined with an echo or Muga scan. The BNP was a blood draw. We said that the care of the patient included positioning, which was semi-Fowler's. We said that this patient would need oxygen, that this patient's drug of choice needed to be an ACE inhibitor as well as diuretics. We needed loop diuretics for this guy, and when it came to the patient having an ACE inhibitor, the ACE inhibitor worked on both afterload and preload. The loop diuretics worked on preload or volume. We said with this guy you needed strict I's and O's and daily weights. We said that they should call us if they have more than 3-pound weight gain in a day and 5 pounds in a week. We said that this patient should have very strict I's and O's and all their IVs on a pump. We further said that this patient would need a low salt diet and a fluid restriction. Both of those nursing measures were going to decrease the preload or the volume that the patient was having. When it came to the patient with CHF, the risk or complication was cardiogenic shock, at which point you were going to see confusion first. You were going to see a low blood pressure, tachycardia, and weak peripheral pulses. The patient was going to need dobutamine at that point, as well as digoxin and Lasix. Dobutamine and digoxin were inotropic glycosides that strengthen the contraction of the heart. The patient who was getting this whole CHF type of deal could have been a patient, left-sided heart failure, could have been a patient that had an MI in the past, could have been an aneurysm in the past, could have been valvular disease currently. But either way you looked at it, it was a serious situation that wasn't going to get better. Just so you know, on the issue of CHF, if we have a patient who's at their last resort, and you can write this on the sheet that says treating CHF. If we have a patient that is on their last resort, meaning right after this is death. If we have a patient that's on the last resort, we have often either given those patients the option of a heart transplant. So a heart transplant could be one of their last options. Or this little deal up here, which is a ventricular access device, which is an artificial pump, ventricular pump that's on the outside of the body. Ventricular access device can be on the left or the right side, either left ventricular access device or right. And this ventricular access device is called bridge therapy. It bridges the patient to the point where they can get a heart transplant. So the ventricular access device is a ventricular pump, because we said the pump was broken. We said earlier the pump was broken. And this is very often bridge therapy between now, which is death, and a heart transplant. Now, we've gotten so good with these that we're going to stop probably calling it bridge therapy and say it's therapy, because it's as good as a heart transplant. It's really amazing. So, but you do need to know the bridge therapy language for your finals. The aortic balloon is an emergency treatment for this patient that we'll talk about later, because all of this is acute. This is acute cardio treatment. But we'll talk about it later. But you just need to know, oh, okay. They look like they're suffering greatly. They may need an aortic balloon. They may need a ventricular access device, yada, yada, yada. But that's all acute. Okay, so that's that. Now,